another edition of the MarkeTech Group Minute. Back in the fall of 2004, when the Minute covered this topic of telehealth or telemedicine, it was not really widespread. However, recently, telehealth, telemedicine appears to be a very trendy topic. So we're revisiting with Dr. Thomas Nesbitt, who is the Associate Vice Chancellor for Strategic Technologies at the University of California, to help revisit this topic and give us an update on what's going on. So, Dr. Nesbitt, thank you again for joining us today.
Glad to be here.
Well, I recently read in the news that California launched the largest telemedicine network in the country, and that was made possible with the help of the Federal Communications Commission. So my first question is why have and how have telecom companies become involved in telemedicine?
Well, I think the why, in terms of why they've been becoming involved in telemedicine, has to do with the fact that a lot of telemedicine applications require broadband, and obviously it's a potentially a new market or a market that they can add new services in, and that's healthcare. Healthcare is a huge part of the economy, and if there are a number of technology or broadband dependent applications, telecom companies are going to benefit. I also think that a lot of the companies see that the direction of healthcare is moving in terms of the location that care is provided to being more distributed, not just to hospitals and clinics, but moving to patients' homes. And the opportunity to add a service like healthcare to people's homes could drive a lot of consumers to make the decision for certain broadband services that they may not just get if it was only entertainment or something else that required them to get broadband.
Mm-hmm. So you mentioned broadband. What other technological advances in the past few years have sort of allowed this process to happen and maybe encouraged traditionally non-healthcare companies to really increase their involvement in telemedicine, telehealth?
Well, I think there's a number of things. I think just stepping back, it's not just wireline broadband or wired broadband. There's also a number of applications that require wireless. And I think the other types of companies getting involved are device application providers, particularly with wireless solutions that simple health-related programs that can reside on a mobile device. Such things as programs for diabetics to keep track of their blood sugars on their mobile phone. But also we're going to be moving into seeing things like body sensors that use Bluetooth technologies that will aggregate to a mobile device, aggregate physiologic data to a mobile device that can be downloaded to the doctor's office. Those kinds of applications, I think, are going to bring a variety of companies into the marketplace. I also think that some home health devices that a number of companies are beginning to think about, and some that are already out there, are going to allow some of the care that used to occur in the hospital to possibly occur in the home, or some of the care that used to occur in the doctor's office can occur in the home now. So I think a number of devices that range all the way from wearable body sensors to devices in the home that allow for chronic disease management, to video conferencing video conferencing devices that allow people to communicate with their doctor, their nurse, their physical therapist, etc.
Mm-hmm. And so you mentioned some applications that may be growing, and it sounds like it's a patient to physician type relationship. What about sort of the remote procedures or remote treatment? Do you think telehealth or telemedicine is ready for that step forward in the direction of providing treatment from remote locations?
I think we're very, very close. If you mean by rather than just consultation, if you mean actual treatment, I think there is an increasing interest in the use of robotics for remote surgery. The idea being that, particularly as we're beginning to do more minimally invasive surgery and using, robotically controlled instruments to do parts of that surgery, if you can control it from across the room, and if the communication uses internet protocol to do that, you can certainly go from one facility in one geographic location to another facility. There have been some surgeries already done remotely, but I think those are sort of the extreme broadband applications that are something that I think there are a lot of people interested in. I think the critical communication piece of this, though, is explicit quality of service, because you can't afford to have that stream that includes both a 3D video, essentially using two separate cameras, as well as the robotic control to be disrupted in any way. But I do think people are beginning to think about that. At least things like beginning with telementoring of surgeries, intraoperative consultations, and other things in the hospital.
Mm-hmm. And what would you say the sort of the legal environment is, and how would that need to change in order to support this sort of change in habits?
That's a great question, because I get asked that frequently about what are the malpractice implications of this in terms of, does this increase people's liability because they weren't there with the patient? And although on the surface that seems like a major concern, so far there hasn't been a lot of malpractice activity around telemedicine. Now, it's not to say that won't grow, but I think there's also, on the other side of the issue, there may be some protection for providers in remote locations that are, in the past, have been making, critical decisions on their own, or doing procedures on their own without expert advice. And you could argue that if there are, two clinicians involved, one more expert than the other, and that someone sought out someone's advice that was more expert than them, there is some protective effect by having telemedicine available, at least to the remote side provider. Now, from the expert provider, from the the large academic health system, I think that there certainly is concerns among some people that will they be at greater risk. I think that as long as there are very clear protocols for how it's done, that if a provider feels that they can't do at least as good of a job in person or over the video as they could do in person. So if they were if they felt that they couldn't do as good of a job using telemedicine as they could do having the patient come in person, then I think if they say, I need you to come in, or I feel like I should do this procedure in our own hospital, I think that is sort of the way to protect themselves. Finally, I would say on that point that some of the interventions that need to occur really require just-in-time expertise, and you lose the opportunity if you wait. The example would be the critically ill or injured child in an emergency room where you only have minutes to make a diagnosis and begin a treatment, and you bring in a pediatric critical care physician from a distance that says, that isn't this disease, it's actually this disease, and the treatment's different, etc. I think that those kinds of things may be very beneficial from a medical malpractice situation to small and remote hospitals that don't see high volumes of certain kinds of conditions.
You touched on a very interesting point, and that is what sort of limits do you see in the technology right now that need to be overcome in order for telemedicine to continue to expand?
Well, I think it's progressing. I mean, I think that as we're moving towards high definition, I think people are beginning to feel like they can even communicate with patients better. They can see facial expressions better. They can look at movement that isn't pixelated when somebody moves their hand if they want to demonstrate a motion. But the reality is that currently telemedicine is limited to sight and sound. There isn't the ability for touch. We do have the ability to do some robotics, but I think there's some people that are working on things like a glove that a provider at one end puts on and the expert provider puts on at the other end, and you can feel what somebody else is feeling. But a lot of palpation, which we call it, palpation that a doc does, is being replaced by things like ultrasound, which are, again, sight related or visual. And I think that we're going to see a lot of instruments like portable ultrasound units and other kinds of units used to replace what doctors used to feel. But again, I think that's a limitation. I think the next sort of, from the video standpoint, I think that 3D kinds of views of things will again be helpful. So you're looking at it in 3 dimensions rather than 2 dimensions. I think that's something that's probably coming and is right around the corner. I also think we're going to see a whole new generation of instruments developed just for telemedicine that will allow people to do, better exams remotely than they're doing today.
So you touched on a couple of different applications. Where do you sort of see the greatest area of growth, or there are a couple of different applications? We talked about some body monitoring. We talked about some surgical applications, and you touched on this portable ultrasound and possible remote viewing, maybe of imaging. Where are sort of the hot spots for telemedicine?
Well, I think from the I think from the volume standpoint, where it's going to grow the most is telemedicine to the home in chronic disease management. I think that represents a huge percentage of the cost of healthcare in this country, patients with chronic disease. And I think that the model that we use today to manage most patients with chronic disease is really not well matched to their disease. So we use an episodic visit model where we collect physiologic data, dependable physiologic data, just in the doctor's office on the date that the patient is seen, versus continuously collecting physiologic data from the patient's home and doing mentoring and coaching of the patient remotely on a regular basis, maybe once or twice a week by a chronic disease management nurse or something like that. So I think those applications are really going to grow. I think the barrier to it right now is the reimbursement models don't incentivize that type of management, but I think the reimbursement models are being changed so that that will be incentivized. I think from the licensed facility to licensed facility kind of applications, I think that almost all the specialty applications in the outpatient specialty consultation applications are growing, particularly in the real simple or the real easy ones to do, like telepsychiatry is easy to do and it's a high demand. It doesn't require a lot of physical examination usually. I think that some of the other areas that are going to grow significantly are the ones that lend themselves to asynchronous telemedicine, like that are store and forward. Dermatology, where you can fill out a template about a skin condition and attach pictures to it and send them to a dermatologist to look at. Ophthalmology, particularly retinal screening for diabetics, which is something that diabetics need to do annually, to have someone look at their backs of their eyes, their retinas, to make sure they're not getting diabetic retinopathy. Those are much more efficient ways for specialists to see patients rather than have a patient come in, sit in a waiting room, be taken back to a room, occupy a room, have a doctor walk in and look at their eyes, versus having in the primary care doctor's office during their regular visit, having a non-mydriatic camera or a camera that doesn't require dilation of the eyes. They snap pictures and send it off to a retinal specialist, and all the normal ones they can go through and say, that's normal, that's normal, that's normal. Oh, I need to see this one because they may need some treatment. You're more efficiently using the specialist's time using those asynchronous or store and forward applications. So I think those are going to grow significantly as well.
And you touched on a very, obviously, very critical point, which is reimbursement is probably among the most challenging elements for the business model of telemedicine. What is sort of right now the most accepted business model in telemedicine services? In other words, who's getting paid for what?
Well, right now it depends on the state that you're in. In California, we get reimbursed for specialty consultations. The specialist gets reimbursed for live interactive video consultations, except in ophthalmology and dermatology, they get reimbursed for that, for live, but they also get reimbursed from the state Medicaid program, Medi-Cal. They get reimbursed for store and forward telemedicine in ophthalmology and dermatology. So, a lot of the reimbursement models depend on video-based consultation from originating sites, meaning where the patient is. The patient needs to be in a doctor's office or a hospital or some sort of a clinic situation. In general, the home, and there's different reimbursement, rules in different states, etc. But and even Medicare, there isn't a direct reimbursement from the home for a doctor seeing a patient in a home, billing a fee-for-service visit. I think when we change the reimbursement models to models that reward clinicians for limiting number of visits and seeing patients more efficiently, I think you'll see the other other kinds of applications grow. But again, just in summary, right now, the most commonly reimbursed type of telemedicine is live, interactive, video-based consultation from one licensed facility to another sort of licensed facility in general.
I see. So what that means is, so is there a separate reimbursement fee, meaning that there's where the patient is, they'll get reimbursed for the equipment use, and then, of course, where the consultation happens, that physician gets reimbursed for the consultation fee? Is that how it's set up, and should it be set up that way?
Well, yeah, again, it differs in different places, but there is some reimbursement models have an originating site fee, which means you get $20 for being the originating site. Both sides of the consultation can be reimbursed. You can reimburse the primary care physician if they actually do something that would otherwise be reimbursed. So the example would be that if a endocrinologist sees a diabetic patient over distance, and the endocrinologist recommends a particular kind of treatment for that patient, and the primary care physician then following that, talks to the specialist, and then following it adds some additional components to the patient's care. They educate them about their diabetes. They also, do some checks on a neurologic exam to make sure they're not getting diabetic neuropathy. They could get reimbursed for that. One of the problems has been some of the computerized reimbursement systems have been set up so that a single patient being billed for the same diagnosis on the same day, it won't allow for payment to occur to two different providers. And a lot of the systems are being fixed. But there is a way in a lot of these, for a lot of payers, that they will pay both sides of the visit to some degree. And again, it's not adding costs, because in the old model, in the traditional in-person model, the consultant would almost always send the patient back to the primary care physician with a letter saying, I'm recommending this, this, and this. Those visits are just sort of occurring essentially back to back.
So what's the value proposition, and probably more specifically for the payer? We've some of us who've been researching this area know the sort of the CardioNet story and the issues that they had with reimbursement there. So what do payers need to be convinced of in order to start reimbursing for telemedicine procedures?
I think that what payers need to be convinced of is that the right care at the right time is the most cost efficient. One of the fears is that by opening up telemedicine, that you lower the threshold for specialty consultation, and that adds additional costs, and that all of those patients wouldn't have gotten in to see specialists in the old model because specialists are backed up and the primary care physician may try something, that might work. But I think the alternative is that because pharmaceutical costs are so high, a lot of primary care physicians may be trying different expensive treatments that may not work. And if the very first time they have a complicated patient, if they can get a specialist to see that patient and the right treatment is prescribed at the very early in the patient's condition, that may be cheaper. The other thing that they need to be convinced is that early identification of things like skin cancer, particularly things like melanoma, that patient is much cheaper to take care of early in stage than if they go on to where they need much more treatments. I think the third thing is that in general, the cost of ancillary tests and x-rays and things like that, may be lower in remote and rural areas than they would be at a large tertiary quaternary medical center. And if you can keep patients in their local communities and keep their care in their local communities. It may be less expensive. It also helps support the local facilities, like the local small hospital that's now getting the laboratory work and the x-rays done locally, rather than when the patient comes down to the large tertiary center and has to have all those tests done there that the specialist orders.
So is it that the payers right now aren't convinced of all these properties that you just mentioned? Or, I mean, what needs to happen sort of for them to buy in and start more widespread reimbursement of telemedicine?
I think they are buying it. Some of the payers are very supportive of telemedicine. Some of the third-party payers are actively promoting it and trying to find specialist providers that will do telemedicine. So I think they are getting increasingly convinced that this is helpful and is cost effective. And I think that it's really incumbent upon academic health systems that are doing telemedicine to do quality research to show the cost benefit. There's still controversy, and all the studies haven't borne out reduced costs and increased quality. But one of the more studied areas is the remote ICU type of telemedicine that's fairly widespread in this country. There are a lot of places that are using remote ICU combination of monitoring and telemedicine. Some of the early studies showed, really fairly dramatic shortened lengths of stay and decreased costs and improved quality. Some later studies haven't. But I think it really is incumbent upon health services researchers at academic institutions to really show, how and where the use of technology-enabled healthcare models save money and improve quality.
Okay, let's switch gears a little bit and just say I wanted to see if you've noticed any differences between telehealth in Europe versus telehealth in the United States.
I think there are some, there is telehealth being done in Europe in a lot of places, and I'm not familiar with in depth what's going on in a lot of countries, but certainly there is telehealth that's happening, in many countries. Some of which is isolated to certain specialties. I think it will grow in those countries, particularly where they have single-payer health systems and those kinds of things. I think that you'll see more and more of that. But, in general, I think telemedicine is practiced fairly similarly, on a per specialty basis, around the world. But my expectation is it's going to grow in other countries, just like it's growing in the United States. I think the limitation in some countries is the cost of equipment and in some countries the adequacy of telecommunications. But I think as wireless applications grow, I think you're going to see more and more telemedicine, everywhere around the world.
Mm-hmm. And do you think that it's going to grow faster in the U.S. just because of the influx of technology, or you think the other parts of the country, other parts of the world, maybe Europe, or are there pockets of areas that may grow faster, or do you see an even growth all over the world?
I'm not sure. I think there's, the United States, we love technology. We spend a lot of money in our healthcare system, so relatively, it's not that expensive in the United States to do telemedicine. But in some of the other countries where their reimbursement models are more conducive to using telemedicine. I think that's the factor that's going to cause telemedicine to grow in other countries maybe faster, because ultimately I think reimbursement and the incentives for using new models of care is going to be the ultimate factor that determines whether it gets incorporated as standard of care or not.
Okay, I see. So final question, and that is, how should telecom companies or medtech companies that are not currently involved in telehealth, but they're interested in expanding into telemedicine, how would they get involved?
Well, I think that they matching their strengths and their technologies to healthcare is often sort of hard to do in a vacuum. And I think working with large healthcare organizations that are already doing telemedicine and trying to really understand what things aren't happening now that need to happen. What is the barrier for a certain kind of specialist really doing a quality exam that they think that they wish they could do something better, and then having companies figure out how what they do can help. And I think just like a lot of the technology companies that are developing things like 3D televisions and those kinds of things, I think people like that can get involved. I think, companies that are developing devices, I think there's a number of companies that are developing applications for, iPhones and other mobile devices, could think about what kinds of healthcare issues might be amenable to that type of use.
Very good. Thank you, Dr. Nesbitt.